the cases for us transplanters is pretty standard. I'm rounding on the floor right now on approximately 15, 16 patients, and we have at least 3 similar cases. So this is the bread and butter of what we do in bone marrow transplantation. So the initial presentation is a 61 years old man that presented with generalized periodic rash, abdominal pain, and diarrhea, approximately 8 to 12 bowel movements a day. That's probably equivalent to 1,200 to 1,600 cc's per day. The past medical history, he underwent haploidentical allogeneic hematopoietic cell transplantation for AML approximately 40 days ago. And reviewing his labs, his platelets are 75,000, ANC 0.7, so he's neutropenic. He jaundiced, comes with a bilirubin of 8 milligram per deciliter, and the rest of his LFTs are okay. Hepatic viral testing, as well as EBV, CMV, HHV6, were all negative. Stool studies were negative. He underwent a FLIC-SIG with a biopsy, and he has lower GI moderate mixed inflammation in the lamina propria and scattered apoptotic bodies without correct loss. Very classic for lower GI graft-versus-host disease. His skin punch biopsy shows hyperkeratosis, hypergranulosis associated with lichenoid inflammatory infiltrate. So all in all, he's a modified Glucksberg criteria grade 3, MAGIC criteria grade 3 as well. Classically, the treatment is systemic corticosteroids, prednisone 2 mg per kg per day, plus topical steroids. After 5 days, there was no treatment response, and he was started appropriately on ruxolitinib 5 milligram orally twice a day. That was increased to 10 milligram orally twice a day on day 6. Very classic case of a man with acute myeloid leukemia who is older, which is, again, appropriately the average age for allogeneic transplantation, at least in the US. He undergoes haploidentical transplant, and he suffers from acute graft-versus-host disease, which affects approximately 40 to 80% of all comers. 50% of these patients will respond to first-line treatment, high-dose glucocorticosteroids, and 50% will not respond. So he falls at the 40 to 80% of patients suffering from this very common side effect. And his prognosis will depend very largely on his response. But if I count all comers like him, because he did not respond to the first line treatment, and the REACH1 trial, the 6-month non-relapse mortality was approximately 50%. And at 1 year, the non-relapse mortality was 60%. So his prognosis, as far as graft-versus-host disease, he has, now that he started ruxolitinib, he has 50% chance of responding. As far as survival, he has approximately 50% chance of dying from either graft-versus-host disease or other causes other than relapse at 6 months.